Welcome to this educational program.
This module discusses the human papillomavirus and the HPV vaccine. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider and may not address all of the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or skip through them in any order you wish. Human papillomavirus, HPV, is species-specific and only affects the human race. It can cause diseases of the skin of the genital areas, the face, hands, and feet, as well as the inside of the mouth and the lining of the upper respiratory tract around the vocal cords. Usually, it manifests as warts at these locations. However, it can also cause cancer of the affected skin. HPV infection is the most common sexually transmitted disease in North America, and an estimated 75 to 80% of sexually active adults under age 50 can expect to acquire an HPV-related genital tract infection. Transmission occurs through close personal skin contact as well as through vaginal or oral intercourse. A baby can also acquire HPV inside the mother's womb or during passage through an infected birth canal. Most people are symptom-free and hence do not know that they have acquired the virus. Certain risk factors are associated with HPV infection and persistence of infection. These factors include multiple sexual partners, anal intercourse, first sexual encounter before age 17, smoking, use of the birth control pill, intercourse with an uncircumcised male partner, and young age. A majority of infections occur in men and women in their early 20s. It is common for HPV and HIV, as well as other sexually transmitted diseases, to coexist. HPV thrives in moist areas of the vulva, anus, vagina, and cervix. The cervix is located at the bottom or lower end of the uterus and is the most frequently affected. There are many types of human papillomaviruses, HPVs, distinct in their genetic material. So far, approximately 100 types have been identified. Of the HPVs infecting the genital areas, 25 are considered low risk and associated with warts, while 13 are considered high risk and associated with cancer. Early detection of HPV can be accomplished via the Pap test. The landmark study describing the technique for performing the Pap test was published in 1941 by Georgios Papanikolaou, a Greek gynecologist. Since the widespread implementation of the Pap test, cases of cervical cancer due to HPV have dropped by nearly 70%. The Pap test does not identify HPV types, but rather the viral effects on the cervix and vagina. It takes on average 10 years for invasive, life-threatening cervical cancer to develop from an HPV lesion. By identifying and treating these initial lesions early, doctors can prevent cancer. Nowadays, most cases of cervical cancer in North America occur in women who have never had a Pap test or who have not had one in the past 5 years. The Pap smear is performed during a speculum examination in the doctor's office. A tiny brush and/or a wooden stick called a spatula are used to remove a few cells from the cervix or the top of the vagina, if the cervix has been removed. These cells are placed on a slide or in a liquid, which are then transported to the laboratory to be examined under the microscope. HPV has a very distinctive effect on these cells. These cellular changes can be of benign, precancerous, and cancerous types. Screening guidelines for HPV are derived from the American Cancer Society and the American College of Obstetrician Gynecologists. All women should be screened on a regular basis throughout their lives. Screening via Pap smear should start 3 years after the first sexual encounter and no later than age 21, and should be performed once a year until age 30. Thereafter, Pap smears can be performed once every 3 years if no additional risk factors for infection exist. Screening may be stopped after a total hysterectomy, which involves removal of the cervix along with the uterus, as long as Pap smears had always been normal and the hysterectomy was performed for benign indications such as fibroids, excessive bleeding, or prolapse. However, controversy exists and some doctors continue screening with pap smears of the top of the vagina even after hysterectomy. Screening can also be stopped at age 65 to 70. Of course, individual risk factors have to be carefully taken into consideration by the treating doctor. It is also possible to analyze the HPV type in the cells and classify it as low risk or high risk. However, HPV typing is not yet an established screening technique. It is usually used once an abnormality is detected on pap smear to predict if this abnormality will stay benign or regress if a low-risk HPV type is present, as opposed to progressing to cervical cancer if a high-risk HPV type is present. The pap smear is a screening test and is not used to make a diagnosis. Abnormal pap smears may create unnecessary anxiety. A pap smear abnormality does not imply the presence or future development of cancer. The vast majority of women with abnormalities can be monitored until the lesions regress on their own, or treated long before cancer develops. Several pap smear abnormalities have been described and include atypical squamous cells, ASC, low-grade squamous intraepithelial lesions, LGSIL, high-grade squamous intraepithelial lesions, HGSIL, glandular abnormalities, and cancer. In order of severity, from least to most severe, the cellular changes can be described as ASC-US, ASC-H, LGSIL, HGSIL, glandular abnormalities, and cancer. Atypical cells are classified as either ASC-US or ASC-H. Changes to these cells aren't usually serious, but further testing may be needed. LGSIL, or low-grade, changes are mild and revert to normal in approximately 80% of cases. High-grade lesions and glandular abnormalities should prompt immediate referral to a gynecologist, as they can be precancerous HPV-related lesions of the cervix or even non-HPV-related cancers of other areas in the upper genital tract, such as the uterus, the fallopian tubes, and the ovaries. Depending on the pap smear result, a referral for colposcopy may be given. During a colposcopy, a large magnifying instrument, called a colposcope, is used to visualize the cervix and upper vagina after application of vinegar to highlight abnormal areas. Biopsies may be taken and sent to the laboratory for further analysis. HPV is difficult to treat or eradicate once established. Treatments for benign warts can be patient or physician applied and consist mainly of solutions which destroy the visible lesions but do not kill the virus. Despite treatment, HPV can return at a different location in the future. Available treatments usually cause burning, pain, itching, redness, and sometimes ulceration in the areas where they are applied. Warts that are resistant to applied solutions can be surgically removed with laser, electrosurgery, or scalpel. Patients with atypical squamous cells of undetermined significance, or ASCUS, category can be sent for colposcopy, can receive HPV typing, or can just have a repeat pap smear 6 months later. The second approach is usually preferred. If the culprit is a low-risk HPV type, most lesions resolve on their own, and the pap smear can be repeated 1 year later. If, on the other hand, a high-risk HPV type is detected, immediate colposcopy is recommended. Lack of estrogen can cause this abnormality. Hence, in post-menopausal women not taking hormone replacement therapy, a trial of vaginal estrogen is recommended and the pap smear is repeated after completion of treatment. All patients with atypical squamous cells, which can't exclude HSIL or ASCH, are sent for a colposcopy. Patients with low-grade squamous intraepithelial lesions, LGSIL, are sent for colposcopy to ensure that a more severe lesion is not missed. After an appropriate time of surveillance with colposcopy, during which the lesion may regress, treatment may be offered to remove the abnormal cells. The majority of low-grade lesions are cleared by the body's own immune defenses without further treatment. Patients with high-grade squamous intraepithelial lesions, HGSIL, are immediately sent for colposcopy and require surgical treatment to remove the abnormal cells. Close supervision by colposcopy is required even after surgery, since 20% of these lesions progress to invasive, life-threatening cancer if untreated or partially treated. Patients with glandular cells detected on their pap smear are in a special category, since glandular cells may signal the presence of other diseases of the genital tract, which may not even be related to HPV. There are glandular cells in the upper genital tract, the inner lining of the cervix, the uterus, the fallopian tubes, the ovaries. When detected in a pap smear, their exact source needs to be elucidated, and further tests are undertaken, including a scraping of the inside of the cervix, a biopsy of the uterine lining, and occasionally a pelvic ultrasound. Treatment varies and is based on the diagnosis. Some of the surgical procedures applied to the surface of the cervix to remove abnormal cells are cryotherapy, which uses ice to destroy these cells. Electrosurgery, also known as LEEP, or loop electro-excision procedure, which uses an electrical current to remove these cells, laser, which uses a high-intensity light beam to burn these cells, and last but not least, a knife excision. The first 3 procedures can be undertaken in the office after using local anesthetic to freeze the cervix, while the knife excision usually requires stronger anesthetic and is performed in the operating room. So far, we have seen that HPV is difficult to treat. Therefore, medical efforts have focused on prevention strategies. Strategies to prevent HPV include the use of condoms and, more recently, an HPV vaccine. Condoms are not entirely protective, since transmission has been shown to occur manually during foreplay, during non-vaginal sex, and from the scrotum or the genital skin that is not covered by the condom. Spermicides do not protect against HPV. A new HPV vaccine called Gardasil has been approved by Health Canada on July 18, 2006, for prevention of HPV-related genital tract disease. It became widely available from doctors' offices and pharmacies in August of the same year. Pharmaceutical companies continue work on other similar vaccines which have not yet received approval from major health agencies in North America. Currently, Gardasil is approved for girls and women aged 9 to 26 and given in 3 intramuscular injections. The first dose is followed by 2 more, 2 and 6 months later. It creates immunity against 4 HPV types, 6, 11, 16, and 18. Type 6 and 11 are low risk and associated with 90% of genital warts. Types 16 and 18 are high risk and responsible for approximately 70% of cervical cancers worldwide. There is no vaccine covering all HPV culprits. However, by targeting these 4 HPV types, most HPV-related disease can be potentially eradicated. Many questions still await answers from clinical trials. For example, would vaccinating men prevent cervical cancer in their female partners? And what is the duration of the protection from the vaccine? Is it lifelong? Or will a booster be required sometime in the future? Also, vaccines which would cover other HPV types need to be developed. After learning about HPV and the HPV vaccine, it is important to remember several things. HPV is a common sexually transmitted virus. It causes benign, precancerous, and cancerous changes of the lower genital tract that can be picked up by a pap smear. An abnormal pap smear does not mean cancer is present. All women need regular pap smears to pick up abnormalities that are curable. It is also important to remember that the use of barrier contraception, such as a condom, does not fully protect against HPV. However, a new vaccine called Gardasil is available for women 9 to 26 years old. Gardasil prevents genital warts from HPV type 6 and 11, as well as precancerous and cancerous changes from HPV types 16 and 18. This slide lists some of the many resources available where you can find more information about HPV. This slide lists several of the references used to help ensure medically accurate information. We sincerely hope that this module has furthered your understanding of the human papillomavirus and the HPV vaccine.
We wish you the best for the future, and thank you once again for viewing this educational program.